Welcome to the breast cancer session for the Radiation Oncology Virtual Education Medical Student Edition, Summer Part 2. We have an awesome lineup this afternoon, like always, featuring today Dr. Ainsley Janowski, who is in Charlottesville at UVA. We've got Bethany Anderson from the University of Wisconsin, and Christiane Takita, who is in Miami at the University of Miami. You want to go on to the next slide. These are their lovely headshots. If you would like to each introduce yourselves, maybe say a little bit about your role and what got you interested in radiation oncology. We'll start with you, Dr. Janowski.
Hello, my name is Ainsley Janowski. I work at the University of Virginia. I specialize in breast cancer and GI cancers. I found radiation oncology sort of late in my fourth year, actually in between my third and fourth year at medical school, by happenstance. I was just looking for something that incorporated a lot of evidence-based medicine, research, cool technology, and actually seeing patients. And it was exactly what I was looking for and loved it as soon as I did a rotation.
Great. Dr. Anderson?
Yeah, hi. Thanks for inviting me to be part of this today. My name is Beth Anderson, and I'm at the University of Wisconsin. I'm a radiation oncologist that specializes in breast and gynecologic cancer. And like Dr. Janowski, I too found radiation oncology relatively late. I didn't know it existed until about my third year of med school. I like to call it the best kept secret in the basement. So I was interested in oncology and took a radiation oncology elective rotation just to kind of see what that was all about. And I immediately fell in love with it because of the variety of procedures, if you want to, plus patient care, plus, yeah, really evidence-based approach to medicine. So that's my story in a nutshell.
Great. And Dr. Takita?
Yes, thank you for the invitation. I actually, when I started looking for residencies, I would love to take care of patients and wanted to do something that I would do research and work with in academics. And radiation oncology has everything together. And really, I felt in love with the variety of diseases and procedures. And I'm impassioned to that. I'm worked with at the University of Miami for 21 years. Doing breast cancer. I initially thought I was going to do pediatric radiation oncology. When I came here, there was we didn't have a large pediatric population, so they offered me a practice in breast, and since then I love it. I've been taking care of my breast patients, and I really enjoy it. It's such a wonderful, wonderful specialty, and I love to work in academics with medical students and residents. I was previous program director, and this year I became vice chair of education, and I passed my position to one of our lovely physician, Dr. Laura Wang.
Great, thank you. Jacob, I'll let you introduce yourself. You're going to be the moderator.
Yeah, thank you, Dr. Fields. My name is Jacob Miller. I'm in my last year of residency in rad onc at Stanford, and I've had the opportunity to be part of the ROVER program for a while now, and it's just been great. Kind of continuing the theme with the faculty panel. I didn't know about rad onc until late in medical school, but it's through some mentors that I found the field, and I can't believe I'm almost done with my training.
Yay. So just some rules for this afternoon. Dr. Miller is going to walk us through some cases. Our panelists are going to discuss. Please make sure if you have questions, type them into either the Q&A or the chat, and just make sure that your settings are set to all panelists and all attendees so that we can get a chance to either ask them live or answer them in the chat. Okay, enjoy.
All right, so we'll start with the first case, and these are all cases that I've actually seen in the course of my training. And this is, first is an early stage invasive breast cancer. So I'll just present the case and then here's some information from our panelists about how they would work up the patient and provide treatment recommendations. So this is a 55-year-old woman who presented to our clinic with a self-palpated lump in the left upper outer breast. So just to start off with, maybe Dr. Janowski, if you could kind of tell us a little bit about when you see a patient maybe with breast cancer or a new finding in the breast, what are the essential components of the history and physical that are important to you?
Yeah, so for the history, I'll focus on that first. I think you really want to ask questions that are relevant to determine what their risk factors for breast cancer are. So in components of the history, you're going to be looking at any family history of breast cancer that might predispose them to like a BRCA mutation or something like that. A history of breast cancer, it could be a recurrent breast cancer, prior radiation exposure, certain patients who maybe have had some radiation to the middle part of the chest might be at an increased risk of breast cancer, and components of unopposed estrogen. So if they had nulliparity, late first pregnancy, if they're on estrogen replacement, early menarche, late menopause, all those things will be unopposed estrogen components that might increase their risk of breast cancer. But for this particular patient, you know, she's self-palpated a lump. I'd want to know how long it's been there, you know, where it's located, if there's been any skin changes, if there's been any other lumps, maybe in the axilla, if she's had any mammograms in the past that we can compare it to, any prior biopsies. And then for the physical exam, it would be a focused physical exam, focusing on the breast tissue, inspect for symmetry, nipple inversion, skin changes, any axillary lymphadenopathy.
Thank you so much. Yeah, so for this patient, you can see the information there about kind of estrogen exposure. This specific patient didn't have any strong family history that would raise concern for an inherited BRCA mutation, similar. No previous breast biopsies. The patient did have a screening mammogram about a year ago that was normal. On exam, the really notable finding was a 2-centimeter mobile lump in the upper outer quadrant, 4 centimeters from the nipple. And there was no adenopathy palpated. So for our first audience poll, question is, how would, you know, if you saw this patient maybe in internal medicine clinic or what would you order next? What would be the first component of workup? All right, so we can see the results there. So most people recommended a diagnostic bilateral mammogram and a targeted ultrasound. And that'll bring us sort of to the next, that's exactly right. That'll bring us to the next slide. Maybe Dr. Anderson, can you, so a diagnostic mammogram and an ultrasound, what's the difference between a diagnostic and a screening mammogram, and why in this patient would you get that exam? And then if you could also comment on the sort of like the different views, what are we looking at here?
Yeah, absolutely. I love this format with the polls. That's super. And talking about the difference between diagnostic and screening mammogram is something that we really like to emphasize when we're working with new medical students and residents in RadOnc. So I like to call the diagnostic mammogram a problem-solving mammogram. So a screening mammogram, that is what a woman gets when she's just coming through for a routine screening mammogram when there's no known issue. And with that, the radiologist will get these standard sets of views, which are what you're seeing on the left and then second to the left. So the cranial caudal is where they compress the breast from top to bottom. And the MLO is when they compress it sort of sideways. So you can see the pectoralis muscle starting to come in on the top there. And if it was a screening mammogram, the woman would just get those views of each breast and then she would leave, and a radiologist would come along later and take a look at that. And if something was noticed, like what's marked in that red oval, then they'd have to bring her back for the diagnostic mammogram. With the diagnostic mammogram or problem-solving mammogram, the radiologist is actually looking at the images as they're being taken, and they'll focus in on that area that that density that's circled on those views, and they'll usually obtain some additional workup of that. So what you're seeing on the right panels are spot compression views, which are done in order to, they're basically further squishing the breast tissue in that specific region, because if that density was just a little bit of overlapping breast tissue that happened to be overlapping, when you compress it out further, it'll oftentimes smooth out and it'll show you that there's actually nothing there. Because that mass is persistent on those compression views, you know that it's actually a solid mass. And then adding an ultrasound on the same day, that allows you to determine some additional features like, is this a cystic lesion, which is less likely to be malignant, or is it a solid lesion, which is more likely to be malignant? And also you can tell whether or not you're able to see it by ultrasound. If you're able to see it by ultrasound, that would be the easiest way to biopsy it, which would be probably, that's a spoiler alert, but an upcoming step in the workup.
Exactly. Yeah. So spoiler alert, this patient did have an ultrasound-guided core biopsy of this breast mass that was seen on the mammogram and the ultrasound. You can see there are kind of the pathologic features that are noted. And I'll actually, maybe Dr. Takeda, there's a lot of information here just from this biopsy, like basal ductal carcinoma, LVSI, DCIS, ERPR. What is all this information and why does it matter when you're seeing a new patient with breast cancer?
Chris, you're muted. And make sure to talk loud.
I'll apologize. It's a very important information, the biopsy specimen. First of all, is to confirm the patient has an invasive carcinoma, and in this case, it was confirmed. And it's very important to see the features in terms of prognosis of that patient. So we're looking to grade better prognosis, grade 1 and 2 compared to grade 3. The size of the lesion, as you know, stage the patient. If it is less than 2 centimeters, T1, and then above 2 centimeters. And then no LVSI also, if you have LVSI, it has a worse prognosis. The presence or absence of ductal carcinoma in situ, also in terms of planning of surgical excision. And then, of course, one of the most important prognostic features for a tumor nowadays is to classify the hormonal receptor status, estrogen and progesterone receptors. So most common tumors are ERPR positive, like this one, which is considered luminal A in this case, and then HER2 negative. So the patients can be HER2 amplified too, which is a different type of breast cancer, different prognosis, as well as the ones that are hormone receptor negative, considered triple negative breast cancer, which have a more aggressive feature. So all this information coming from a biopsy, first of all, we'll plan what kind of treatment you are going to perform for planning the next phase of these patients in terms of decide what to do next. And why was a marker deployed at biopsy site? Well, that's a very good question, because sometimes the tumor is small, and with the vacuum biopsy, if you don't place a clip, and sometimes it occurs that all the tumor is removed, and when the surgeon is going to do the surgery, if there is no biopsy, no clip, you won't know where this surgery is going to be, where you have to remove the tumor.
Thank you, Dr. Takeda. Okay, so so we have this patient that has had a biopsy and a diagnostic mammogram and an ultrasound. You may have seen in your rotations thus far, this patient would be seen at a breast surgery clinic. So if you were counseling this patient for our next audience poll, what surgical options are available for early stage breast cancers, maybe early stage lymph node negative? So open this up to the audience. So exactly right. Most of the audience mentioned a modified radical mastectomy and lumpectomy. Maybe Dr. Janowski, can you briefly comment on what's the difference between a radical mastectomy and a modified radical mastectomy?
Yeah, so that determines the type of surgery and how much of the tissue is removed are different between the modified and the radical. The radical mastectomy is going to have a full axillary lymph node dissection, and they're going to take a bit of the muscle as well. For the modified radical, that's what's much more common these days. You can do a sentinel lymph node biopsy and remove the breast tissue, and that's basically the component of what that's included.
Yeah, so for this specific patient, after discussion with the surgeon, patient's inclined to pursue breast conservation. And maybe open up to the panel again. For this specific biopsy, would you recommend the patient go directly to surgery or start preoperative chemotherapy? And then a sentinel lymph node biopsy was mentioned. What are the different options for axillary surgery in this situation?
Well, I could continue for in terms of the preoperative chemotherapy. I think when you think about who you should give preoperative chemotherapy to, you should be asking a couple of questions. So is the patient operable? If they're not operable, then that might be a patient you'd consider chemotherapy for to try to get them to a surgery. In the setting of operable disease, what is your chemotherapy helping you with? Is it downstaging patients who have concerning lymph nodes or lymph node positive disease? Is it making patients who have big tumors, smaller tumors, so that if they're interested in a lumpectomy, they can be a candidate for a lumpectomy? Is it delaying surgery? And maybe somebody who's pregnant, maybe that would be something that you would be interested in. Or is it a histology that is going to be very responsive to chemotherapy with someone with a larger tumor or lymph node positive disease? So our patient really doesn't meet any of that criteria. They're operable now, and so they could certainly go on to whichever surgery they think is most appropriate. So I don't think that chemotherapy is going to help them. And then in terms of the axillary surgery, we've really moved to that sentinel lymph node biopsy surgery, where you inject either a blue tracer or radioactive tracer close to where that tumor is located subcutaneously. Whichever lymph nodes take up that tracer, it's usually somewhere between 1 and 3. They're removed at the time of the surgery. That gives us great guidance on how we need to do our radiation, whether or not we need to incorporate the nodal areas in our treatment fields. So I guess I'll stop there.
Yeah, so this patient ended up going to having a lumpectomy and a sentinel node biopsy. And here's the results of the pathology. So we saw the biopsy result earlier, but this is the actual surgical specimen. And just very briefly, it ended up being a 2.3 centimeter tumor, grade 2. It was removed with negative margins. And then the hormone receptor status, the ERPR, was the same. I don't think they retested it. And the patient also had an oncotype score, which was 9. We'll talk about that in a moment. And then finally, in terms of the sentinel node biopsy, 3 lymph nodes did end up getting removed, and none of them were involved with the cancer. So the patient was staged as a T2N0. And you see the patient maybe in your radiation oncology clinic afterwards. And then thinking about this pathology and the patient situation, maybe Dr. Anderson, can you comment on, would this type of situation, would adjuvant chemotherapy be recommended? And what's the purpose of even this adjuvant therapy and adjuvant radiation?
Yeah, great question. So as far as we know, this woman is cancer-free right now because she's had her all known disease resected with a lumpectomy sentinel node biopsy. But we know that there's a risk that she could have cancer spread in a couple different ways. One would be systemically, which would be the main purpose of thinking about something like chemotherapy or endocrine therapy. And we also know that there's a risk that there could be a little bit of residual disease left behind in the breast tissue itself, just sort of in the neighborhood of where that tumor was growing. And that would be the main indication to think about some radiation treatment to kill those specific cells and reduce the risk for a local recurrence. So as far as systemic therapy goes, The Oncotype test, that is a multi-gene test of the breast cancer itself that tells us a couple things. It tells us how likely that cancer is to actually respond to chemo, and it also tells us how likely the cancer is to recur without chemo. So a low Oncotype score of 9 means that this is a cancer that's less likely to come back than some others, and it means one that's not as likely to benefit from chemotherapy. So this is something where we would recommend just endocrine therapy alone, so either tamoxifen or anastrozole to cover the systemic component. And then as far as radiation goes, radiation, just generally speaking, provides about a 2/3 relative risk reduction for risk for local recurrence in the breast. The exact number, is a little bit hard to pin down for something like this. Historical numbers were a 30% risk for recurrence without radiation, 10% with. That's a little high with our current, everything's gotten better, mammograms, imaging, surgery, everything else. So I would generally nudge those numbers down, but that's the general reason to give radiation.
Thank you, Dr. Anderson. And just to recap the information that we have so far, this is a 55-year-old postmenopausal woman. She self-palpated an invasive ductal carcinoma of the left breast. The surgical pathology after the lumpectomy and lymph node biopsy showed a T2N0 grade 2 tumor. It's hormone receptor positive and a low Oncotype score. So maybe Dr. Takita, if you saw this patient in your clinic, what would your recommendation be in terms of radiotherapy? First, does the patient need it? Would you, and what are the different types of radiation that could be delivered?
Yes, basically for this patient, because of her age group, 55 years old, usually recommendation as a standard is to add radiation in the adjuvant setting to decrease risk, as you said, for Dr. Anderson, decrease risk of local regional recurrence. And omission of radiation is being looked into studies, but for older population above 70, it's more common. But for this age group, still the standard is to treat the whole breast. And I would favor, because she has a T2 lesion, even though it's grade 2, I would boost her. So that is a treatment that's offered to her. There's other options, partial breast, but if you look at some guidelines we have for radiation oncology, ASTRO guidelines, usually the suitable candidates, which are the classic indications for partial breast, she has a T2 lesion, so usually we would look for tumors less than 2 centimeters, node negative, which qualify. But I would, in my practice, I would use a whole breast radiation followed by a boost. I would not treat the lymph nodes because patient has node negative disease, so there's no need to trace the lymph nodes. And I think the boost is answered there.
Yeah. Thank you, Dr. Takita. And that was also, when we met with the patient in clinic, that was also our recommendation. So again, another audience poll. We've mentioned whole breast radiotherapy. Part of radiation oncology is seeing patients in clinic, but also part of it is the treatment planning and how to optimally design the radiotherapy. So what's the classic radiotherapy field arrangement when treating the whole breast? We'll give it that some time. Okay, so it looks like most people answered tangential fields or tangent fields. And let's actually go next to field arrangement and treatment planning and talk a little bit about that. So we specifically recommended whole breast radiotherapy to 40 gray and 15 fractions, followed by a boost to lumpectomy cavity. Dr. Janowski, can you explain what we're looking at, and in your day-to-day practice, how does this play into when you're designing treatment plans?
Yeah, so for the audience was absolutely correct. Tangential fields are the way that we're going to be treating this patient. So usually there is a beam pointed to the medial aspect of the breast and one pointed to the lateral aspect of the breast. And you're basically taking that breast tissue and creating a wedge where that's the only thing that's exposed to the radiation. There's a little bit of lung in the field. What we're looking at are some x-rays showing this orientation. So you have a little bit of lung in the field, you have the whole breast, and then you have a little bit of a margin above and below the breast. Now, what we're looking at here is some field and field arrangement. And so what does that mean? It's difficult for something that is has different depths and widths to have a homogeneous amount of dose that's delivered. So what we used to do are wedge fields where we would try to adjust the amount of dose that the breast was receiving in different areas so that you'd basically get the same dose in different parts of the breast. And what we do more in the more modern era is do this field and field arrangement. So you're basically taking small fields with small amounts of MUs, and you're employing those based on the dose distribution to create a more homogeneous field. Why do we want to do that? The degree of heterogeneity that you get in the dose could also contribute to increased rates of radiation dermatitis and could affect the cosmesis in the patient. So when you prescribe your dose, you're hoping that your dose is relatively uniform with hotspots, less than 110 or ideally less than 107%. So when I'm looking at this, we're looking at sort of a color wash. The first thing I'm thinking is we're treating the wrong breast. However, but I think this is just an example.
It's just an example.
What we see is that the color wash is pretty uniform, and this red is representing a slightly higher dose of 105%, if I'm reading that correctly. So that's a relatively homogeneous dose distribution, and I wouldn't be concerned with increased rates of radiation dermatitis unexpectedly so for this particular patient.
Thank you, Dr. Janowski. And so this specific patient completed radiotherapy with some dermatitis, some tiredness. Anastrozole hormone therapy was started after radiation. And that can be associated with hot flashes and myalgias. And then the patient did well, in follow-up, which consisted of physical examinations, annual mammography, and no recurrences were really observed. Just again, opening it back up to the panel, we've talked a little bit about treatment planning and what are some of the expected late effects after breast radiotherapy? How do you incorporate that into maybe advances in radiation techniques? And what are some of the considerations about survivorship that you discuss with your patients and long-term follow-up?
Sure, I can do this one. So when we're talking about the left breast, the main side effects to consider, the most common one would be that the breast could be a little smaller or a little firmer permanently as a result of getting radiation. Sometimes people can get some lymphedema on the breast where the skin has a little bit of a more thickened appearance, but usually these changes are subtle enough that people are happy with it. Some rare delayed side effects could include a broken rib right underneath the breast, or on the left side, something like a heart attack related to the breast radiation itself, or a radiation pneumonitis, so lung inflammation of a little tiny bit of lung underneath that breast. So we take that into consideration when we're designing the beam angles. We try to block out the heart and block out the lung as much as possible. And we've gotten so much better in the modern era with CT planning and breath holds to keep the heart out of the radiation area. So these risks are really, really small. And in very rare cases, radiation can actually cause an unrelated cancer like a sarcoma in the chest wall, right in that area that's being treated. So those are things that I tend to remind patients of when I'm seeing them, for their delayed follow-ups. Remind them gently and remind them that these things are rare, but we do keep on the lookout for them. And then as far as endocrine therapy goes, you've got a couple things listed there: hot flashes, myalgias. With anastrozole, it's really important that bone mineral density be followed closely because that can thin the bones out over time. And some people can have some pretty painful thinning of the vaginal mucosa that can be a quality of life issue. So I like to be sure I ask about that as someone who also treats people with gynecologic cancer.
Thank you, Dr. Anderson. So we'll go to the next patient that that will be presenting today. And this is another patient I saw during one of my rotations. This is the sort of other side of the spectrum of breast radiotherapy, which is a lymph node positive breast cancer. So I'll just present the initial presentation. So this is a 40-year-old premenopausal woman who also self-palpated masses in the right breast. In terms of relevant history, you can see the estrogen exposure, family history. She did have an ovarian cancer in a first cousin, but no other relatives with breast cancers. No previous breast biopsies. Also had a screening mammography 8 months ago prior to presentation that was normal. On physical exam, the right breast was slightly enlarged. There were no obvious skin changes or nipple retraction. But on palpation, there was an ill-defined firmness in the upper outer quadrant and the subareolar region. And in the axilla and the supraclavicular fossa, there were multiple enlarged axillary lymph nodes that were palpable. And just like the previous patient, a diagnostic bilateral mammogram and targeted ultrasound were ordered. So these are this is the mammography. It did show heterogeneously dense breast tissues. There's really no specific masses seen on mammography or on ultrasound, but as shown by the arrow here, there were large axillary lymph nodes that were noted. So, Dr. Takeda, why the breast is asymmetrically enlarged, but there's nothing really specifically seen in the breast? Why might a young patient not have a mass seen on mammography? And would you order any additional imaging to evaluate this?
Yes, for the younger patients, usually you have a very dense breast. And what happens is that, like you can see on this one, you see the density, which is the white part, and then the mass could be hidden behind that, and so you wouldn't see it. So most of the cases for patients that have extremely dense breast, and you cannot find a mass, but it's palpable, for sure, you have to have a MRI of the breast with and without contrast so that you can see better the image. So certainly for this patient that seems to have palpable nodes, that would be for sure, and a palpable mass clinically, but mammographically not correlated. The MRI is indicated.
So I'll just play the MRI for a little bit. And then maybe if our panelists have any comments on it, I can scroll through just as I'm going through.
Yeah, as you can see on the MRI, she has huge lymph nodes in the axilla, as well as it looks like she has an enhancement area in the ipsilateral breast with a large area. Seems quite large, more than 10 centimeters. And also I can see that looks like enlarged internal mammary lymph nodes. So these are all related, could be related to the locally advanced breast cancer in a very young patient, unfortunately.
Yeah, and that was exactly what the radiologists observed too. So there were multiple masses, but just in general, there was clumped non-mass enhancement because contrast was given during the MRI. It spanned about 11 centimeters in the breast, and just correlating with the examination, enlarged axillary lymph nodes were observed, and internal mammary lymph nodes were noted. So the patient was clinically staged as a T3 and 3B. A biopsy was performed, ultrasound-guided. It showed an invasive ductal carcinoma with carcinoma in the lymphovascular spaces. It was not positive for the estrogen receptor, progesterone receptor, but it was HER2 positive. And one of the lymph nodes of the axilla was biopsied. It did confirm breast cancer in the lymph node, and a clip was placed. Just completing this patient's workup, who's maybe at higher risk of the cancer spreading elsewhere in the body, a CT chest, abdomen, pelvis was performed. It didn't show any distant metastatic disease. The patient, partially because of the extent of the presentation and her age, germline genetic testing was performed that didn't show any pathogenic mutations such as BRCA. Dr. Janowski or Dr. Anderson, what would your initial treatment recommendation be for this patient in contrast to the previous patient? and why might you recommend that?
Yeah, I think this patient is the exact opposite of the first patient. She has a very locally advanced breast cancer who could definitely benefit from some downstaging. Hopefully we can make her nodes negative at the time of surgery. In addition, she's got a histology that's very responsive to chemotherapy, ER negative, PR negative, HER2 positive. That's the histology that's the most commonly associated with a pathologic complete response with chemotherapy. So that's a favorable histology for her to receive this chemotherapy, and hopefully we'll get a good response from it.
Yeah, exactly. So the patient did, meet multiple criteria for preoperative chemotherapy. And this specific regimen, TCHP, was recommended by medical oncology. She completed 6 cycles of it, and she did well during chemo. So I think we've already talked a little bit about the HER2 positivity, specifically that there are targeted agents that that can target that specific HER2 amplified breast cancers and are associated with better response. So a repeat breast MRI was performed after the patient completed chemotherapy. It showed resolution of the enhancing mass in the upper outer breast, decrease in size of those large lymph nodes that we saw in the axilla. The internal mammary lymph nodes had resolved, so they looked like normal, and the contralateral breast was also normal. So maybe somewhat controversial, but she did have a really good clinical response and was offered either a modified radical mastectomy or a partial mastectomy with a mammoplasty and sentinel lymph node biopsy. And the patient ended up going for a partial mastectomy and mammoplasty. And maybe Dr. Anderson, when when one of your patients goes and has surgery, what are the key things that you're looking for maybe after chemotherapy on the operative report and on the surgical pathology so you can make a treatment recommendation?
Yeah, so after neoadjuvant chemotherapy, it's really important to see if the most pertinent aspect in this particular patient is this axillary response, as you have highlighted here. So if she has just a sentinel lymph node biopsy done, if there's any residual positive nodes, then completing with an axillary lymph node dissection would be the standard of care. And looking at this description here, it sounds like they probably did do an axillary lymph node dissection. Yeah, so with that that amount of residual disease and 8 lymph nodes removed, that would be, an acceptable number for an axillary lymph node dissection. And so we would recommend, with residual disease, we recommend radiation as well. Well, you would anyway after a lumpectomy. So that would be the next recommendation would be comprehensive radiation to the whole breast, all of those lymph nodes, and a boost to the lumpectomy cavity.
I'll make a comment on this case, if I can.
Yes, of course.
That in my practice, in our center, we would also boost internal memories because it looks like a sizable disease. If it can be safely delivered, we usually do with proton therapy, which just acquired. So I think would be a concern because these nodes haven't been removed. Of course, they had complete pathological response in terms of a clinical response by MRI, but we usually would boost that node.
Okay, and so after surgery, when you see this patient maybe in radiation oncology clinic, just to recap, 40-year-old premenopausal woman, axillary and internal mammary adenopathy seen on MRI, associated with a large tumor in the breast, clinically T3 N3B, no hormone receptor positivity, but was HER2 positive, had 6 cycles of neoadjuvant chemotherapy, followed by a partial mastectomy, mammoplasty, and sentinel lymph node dissection. And it did show residual disease in the lymphovascular spaces and in the lymph nodes. So I think we've covered some of the endocrine therapy, but Dr. Takeda, you kind of brought up how you're thinking about designing your fields based upon the extent of disease initially. So In this patient, in contrast to the previous patient who got whole breast radiation, what areas would you treat, and how would you, deliver the radiation each day?
Okay, of course, after lumpectomy, partial mastectomy, she needs the whole breast treated, as well as the regional nodes, meaning that the nodes that can be involved, including internal mammary, the supraclavicular, infraclavicular, and axilla. In this case, because she had 8 nodes removed, what we would do is we look into the I don't know if that we could be considered a sentinel, so that we would include actually level 1, 2, and 3, because she had bulky disease. So and then finally boosting the areas of probability of high risk for recurrence, which would be the breast area, and then I would boost, and that's controversial, but I would boost internal mammary if I can safely deliver it with proton therapy, which usually we can, the area of internal mammary nodes. The axilla is being treated by surgery too.
Thank you, Dr. Takeda. And I'll briefly show a component of the treatment planning that we do is, of course, CT based. We outline the areas of the lymph nodes, as well as the lumpectomy cavity in red. And then the area in purple are the internal mammary nodes. But I think a nice visualization of this is also like in the previous patient where we're designing the fields themselves. So what are, maybe Dr. Takeda, what are we looking at here, and what are the different volumes that we've highlighted, and how does, yeah.
That's a very nice, this is something that we do every day, and in terms of radiation oncology practice. So what we do is we design the volumes at risk and the normal structures that we wanted to avoid. In this case, we see here the lumpectomy cavity, which is at the high,
Sorry, oops, sorry about that.
So we see the lumpectomy cavity, which is the high risk of recurrence in the breast. As outlined, the breast is going to be treated. It's also outlined. Internal mammaries in pink. Usually is from the first to the third intercostal space, but because this patient had positive internal mammary nodes, they went longer. I imagine that there was some nodes lower than the third. And then also you can see the axilla level 1, which is the one lateral and inferior. Yes, I cannot use the PowerPoint, sorry. And then you see the level 2 and level 3. And then the supraclavicular nodes above the clavicle. So this is a classical design for what we call a 3D conformal treatment for the breast and regional nodes, including wide partial tangential fields. So on the tangent fields, you include internal mammary, so that's why it's wide partial, is wider in the superior aspect, including internal mammary. And then you have so that's medial lateral tangents, like you saw in the first case. And then we have, this is a typical monoisocentric technique, which has the isocenter. Maybe Jacob can put the pointer there, of the isocenter. And then the third field is the supraclavicular axillary field, and that's the third field treating that area. And then we spare the shoulder as well as the spinal cord. Very nice classic radiation field.
Thank you so much, Dr. Takeda. Okay, and then maybe I'll scroll through the panelists. If you, well, here I can scroll through the treatment plan. What are we looking at, maybe from the panelists, when you're evaluating dose distributions for a plan like this? Yeah, as I go through the plan.
Well, what you're generally looking for is to have as little dose as possible into the lungs and heart, and good coverage of what you've outlined as your at-risk area. So the lumpectomy cavity right there in dark red. The whole breast isn't or maybe that's an isodose line, the whole breast there, as well as the supraclavicular and axillary lymph nodes. And I see the internal mammary lymph nodes contoured there and as well in purpley color.
Okay, so this patient completed radiotherapy with, again, dermatitis and fatigue. TDM1 or Kadcyla was actually started after radiation. I think we've talked about a lot of these situations. When you would recommend radiation to the lymph nodes, trade-offs of nodal irradiation in terms of sparing the heart and the lungs, and then some of the techniques with proton therapy and 3D treatment planning. All right, so we have about 10 minutes left, and our last case is ductal carcinoma in situ, which we think of a little bit differently maybe than the previous two cases. So I'll present this situation. This was a 61-year-old woman with no history of breast cancer, goes for a routine screening mammogram, didn't palpate anything, is asymptomatic. You can see her relevant history there, no previous breast biopsies. Last had her annual screening mammogram a year ago. That was normal. On physical examination, everything was essentially normal as well. So here's the screening mammogram. And what it showed in the right breast is pleomorphic microcalcifications with no adenopathy or discrete masses. And there's also a normal ultrasound as well that was prompted by this. Let me see if, I don't think we have a poll for this one, but maybe again to our panelists, when you see pleomorphic microcalcifications, what do you think of? And how is that different than seeing a mass on a mammogram?
You think of ductal carcinoma in situ. So that's often a precursor to an invasive cancer. Invasive cancers are going to present more like masses, though lobular carcinomas don't always present that way. But a ductal carcinoma will typically present with some kind of spiculated mass. For pleomorphic calcifications, you think ductal carcinoma in situ.
Thank you. Yeah, so the patient had a stereotactic core biopsy of this area, and importantly, because it's not seen in an ultrasound, you can't do an ultrasound-guided biopsy. So the biopsy was mammogram guided, and indeed it did show ductal carcinoma in situ. It was grade 2, 1.5 centimeters, and hormone receptor positive. After that, the patient spoke with the surgeon and had a wire localized lumpectomy that showed a 3 centimeter extent of DCIS, also grade 2 with widely negative margins. No axillary surgery was performed. So just to recap, 60-year-old postmenopausal woman, screen detected, ductal carcinoma in situ of the right breast. It's 3 centimeters, grade 2, ER/PR positive, and it's been removed with negative margins and no axillary surgery. The patient is referred to medical oncology and to RadOnc. And opening up to the panel, was there a mistake? Why didn't this patient have any axillary surgery? Do they need to have the lymph nodes evaluated? And what would you recommend for adjuvant treatment?
Yeah, and did they forget to test her for HER2 as well? That's a thing that comes up sometimes with new residents and medical students. So with ductal carcinoma in situ, that we like to say can sort of crawl up and down the milk ducts, but because it's pre-invasive, it's not invading into the breast parenchyma itself. Unless there's a component of invasive disease that was missed, the DCIS itself doesn't actually spread through the lymphatics channels or distantly. And so we don't routinely do axillary staging. And we also don't check HER2 on these because there's no evidence that adding HER2 directed therapy is actually helpful for DCIS. So with this being a low risk DCIS, yeah, she could have either whole breast or partial breast radiation. And because it's ER positive, she can have endocrine therapy as well.
And Dr. Takita, how would you counsel this patient in your clinic, and what radiation might you offer?
Yeah, this patient, I'll definitely, I think she she wouldn't be considered, she has a good risk DCIS, but not considered low risk DCIS because usually it's less than 2.5 centimeters, some technicalities. And in that patient population, smaller tumors, less than 2.5, you could consider with a grade 1 or 2 receptor positive disease with good negative margins, you could consider omission of radiation and hormonal therapy. But in this patient population, I would, specifically her case, I would consider she's eligible for radiation, and she would be eligible for 3 weeks whole breast radiotherapy or partial breast radiation. I usually, in my practice, I like once a day treatment rather than twice a day. I usually like the Italian regimen of partial breast, 30 grazing, 5 fractions every other day, as long as they're not too close to the skin. And then if they are too close to the skin, one of the options, or you cannot, and if you can see the cavity, if you cannot see the cavity well, I usually, and they are eligible for partial breast, like her, I would offer also the import low regimen, which is 40 grazing, 15 fractions to part of the breast. So these are all options available for this lady.
Thank you so much. Yeah, so it kind of speaks to, in breast radiotherapy, how important it is to counsel patients and be familiar with all the different treatment regimens and tailor it to the individual patient. And it also differs by different institutions. So we did indeed recommend partial breast radiotherapy for this patient. We did treat with a BID fractionation, although, yeah, we work with our patients to sometimes do once a day treatment. So here's kind of maybe it looks a lot different than the previous treatment plans, in which kind of outlining the cavity and the dose distribution is a lot different. So just as one of our final questions to the panel, when you treat with partial breast radiotherapy, what's your technique, and yeah, what do you prefer?
I treat them very similarly to Dr. Takeda, 30 gray and 5 fractions, either every day or every other day. Find our patients tolerate it very well. We also have an institutional trial at UVA. I'm not sure if anyone's interested in it, but we also do partial breast radiation using a balloon brachytherapy approach with 1 day of treatment at the time of surgery. So one of those 2 options.
Yes, there's a plethora of partial breast radiation options that exist, and the options we offer are pretty similar to what Dr. Janowski described. Either brachytherapy, which is 2 treatments a day for either 2 or 5 days, kind of depending on the situation. Or I tend to also prefer, like Dr. Takeda said, the 5 fraction every other day partial breast regimen for external beam.
Thank you. Yeah, so this patient did well during radiotherapy, and she actually declined endocrine therapy for this DCIS. Also did really well in long-term follow-up. So just as our last maybe comments from the panelists, really forward thinking, what are some really interesting areas of research in breast radiation that most excite you, and how will the field change?
I think we've done a great job figuring out how to de-escalate radiation in certain patient populations. Our elderly patients, partial breast radiation, shortening the radiation regimen to make it more convenient for our patients who meet certain good criteria. I think the next steps, or the things I'm interested in, are just sort of biomarkers to predict radiation efficacy and treatment response for our therapies that we're offering our patients.
Yeah, that's very interesting, the biomarkers, but also I'm pretty intrigued by these shorter courses of whole breast radiation that are coming out, that are 5 fractions to the whole breast. And how can that be expanded? Is it going to be okay to treat the regional lymphatics at a very, ultra hypofractionated regimen or not? So continuing to push the envelope on how can we limit side effects and limit just the negative impact of radiation on people's lives. Back in the good old days, we had to give 33 fractions to almost everybody we saw, and that was a really big quality of life factor for the women we were taking care of. And so, like Dr. Janowski said, we've made so much progress, but there's still more to be made.
Yeah, I think in breast radiation, I think we evolved so much. And the most important thing is that we did that through randomized trials, which is the answer. So we have a lot of data in hypofractionation and decrease in the number of fractions and similar results for the whole breast and regional nodes accruing more and more. And so I think it's from, as Dr. Anderson said, from 33 fractions down to as low as 5 fractions, which fast forward has. I think it's a major achievement. I think it's what I'm most interested right now is like in terms of partial breast, can we do less in terms of volume of disease of treatment area? So I do have a PI-initiated trial in preoperative radiotherapy. We're using ablative radiotherapy in 5 fractions, and it's a phase 1 trial, so dose escalation for early stage low risk breast cancer, and also looking into the biomarkers of response using imaging blood as well as pathology specimens. So I think it's a very interesting time and a lot of things also to come with the results of other trials.
Wonderful. Okay, well, thank you so much, Dr. Janowski, Dr. Anderson, and Dr. Takeda. Appreciate everybody's attention. I'll turn it over to Dr. Fields and Dr. Khan.
Thank you, everyone. Just a few things for the end of this session. Please fill out the post survey. We do send out 4 Amazon gift cards. I'm sure many of you have gotten them. And you have a pretty good likelihood of getting it. So please fill that out, and it helps us to improve the sessions. Next slide. You can always contact us, and there's a section on the radoncvirtual.com, and you can sign up for any of the sessions on the website. Next slide. There are lots of different opportunities to reach out to different faculty from around the country. Please look at the website. We're always trying to improve that. Our next session will be on September 3rd, and we'll be talking about lung cancers. So please sign up for that on September 3rd. And then right after this, like in a few minutes, is the Applying to Radiation Oncology Residency ACRO session. So you all should register, trying to get into that to watch that. And then lastly, on September 16th, we will be having our networking session where we'll have lots of different institutions so that you can go into breakout rooms and talk to different faculty and residents from around the country, and we'll rotate you through in the breakout rooms. After an hour, we're actually going to have applicants from last year who will be just doing a Q&A session and talking about virtual rotations, the application process, and everything that they went through last year. So there's a few PGY1s who wanted to let everyone kind of know what that's like. And please reach out to us, everyone. Thank you for the session.